Good morning. I think we'll go ahead and get started. I'm John Eaker from UT Dell in Austin.
And Jeffrey Chow from the University of Oklahoma in Tulsa.
So format here is probably most people know, it's a five-minute presentation, then a few minutes for questions. And we'll go ahead and start with laparoscopic common bile duct exploration by acute care surgeons saves times and money compared to ERCP by Alexander Morton.
Morning. Good morning. I'm Alex Morton. I'm a general surgeon at Denver Health in Denver, Colorado. My talk will be on common bile duct exploration. I have no conflicts or disclosures. Historically, the management of choledocholithiasis was by bile duct exploration at the time of open cholecystectomy. However, with the advent of laparoscopic surgery and ERCP, there's been a paradigm shift with the majority of choledocholithiasis being treated by gastroenterologists, either before or after laparoscopic cholecystectomy with ERCP. Wanling and Collings looked at the trends in choledocholithiasis management over a 15-year period, and they found that while the rate of choledocholithiasis remained constant on a year-to-year basis, the overall use of common bile duct exploration reduced dramatically from 40% of all patients in 1998 to less than 10% of patients in 2014. One would think that as the use of laparoscopic surgery increased during this time period, that laparoscopic common bile duct exploration would have increased as well. However, you see there that there's a decrease in laparoscopic common bile duct exploration. This suggests that surgeons are becoming less and less familiar with these techniques and that these techniques are not being taught frequently to our residents. At Denver Health, we have a GI group with one gastroenterologist that performs ERCPs. These are available thus on an intermittent basis, and in urgent and emergent situations sometimes require transfer to an outside hospital. We therefore began performing laparoscopic common bile duct exploration at the time of laparoscopic cholecystectomy at our safety net hospital, with the hypothesis that this would help reduce the length of stay for our patients and provide either similar or reduced hospital charges as well. These procedures are being done by acute care and general surgeons who have no specific fellowship training in choledocholithiasis management. This is a retrospective case control study that matched patients undergoing lap chole with laparoscopic common bile duct exploration versus those undergoing lap chole with ERCP during the index admission. Study period was 2018 to 2020. We compared the demographic values, laboratory values, length of stay, hospital charges, and the number of procedures performed during admission. As expected, the patient demographics were similar, as were their admission laboratory values, including white blood cell count, LFTs, and total bilirubin. Our success rate was 79%, with the remaining 3 patients who were done early in the study period successfully undergoing postoperative ERCP. As you would expect, the median number of procedures between the 2 groups was statistically different, with a median of 1 versus 2 for LCBDE versus ERCP, and there were no major or minor complications in the LCBDE group. Additionally, the length of stay was significantly reduced in the LCBD group with a median of 2.5 days compared to 5 days in the ERCP group. And hospital charges were also significantly reduced with a median of $36,000 versus $48,000 in the ERCP group. This does not include several patients who required transfer to an outside hospital on an urgent basis. We're unable to account for these charges, but this would only serve to accentuate the difference in these costs. So in conclusion, laparoscopic common bile duct exploration is a very feasible and highly successful procedure in the safety net hospital setting, and that its implementation reduces length of stay and hospital charges compared to those undergoing ERCP. LCBD is a valuable skill set that should be utilized more frequently by general surgeons and continue to be taught to the next generations of surgeons during residency. Thank you.
Question.
Hi, Jay Doucette from San Diego. I like a study that supports my biases, but there's a backstory here, which is the technology has changed recently, and it's a lot more new equipment, disposable equipment. So So how do you handle that new cost of acquisition, telling administrators you want to buy expensive disposable scopes, and how do you train your staff to use it?
So it's fairly straightforward to acquire the equipment needed. We just recently went through that process to get the spyglass scopes. The cost of these scopes is fairly similar to what you see for ureteroscopes and the reusable scopes. In terms of training our staff, it required some effort. We definitely had to have some sit downs with the group, make sure everyone was familiar with the equipment, and we have a specialized locker that we use so that when we're going to do one of these, we have all the equipment there and we have a list of instructions for them to do so they can help us get this done. It's not something that you can generally just walk into. You need to have planned for this ahead of time so that your staff understands what they need and can make the process smooth.
Hi, Mentor Amedi Fargo. At our facility, probably the most precious commodity is the time in our acute care room where we do all the lab choles and stuff. I didn't notice in your charts the time that this adds to your cases when you're doing lab chole versus lab chole with laparoscopic common bile duct exploration. How does that affect your day, operative day?
It definitely adds time, and in a standard case, especially early on, it could add, an hour and a half or even more. A lot of that time early on was related to gathering the right equipment, getting everything set up, troubleshooting those issues. As we become more streamlined with this, we can get it down a lot closer to an hour. So it definitely adds time. It definitely takes up operative time, but that is outweighed, I think, by the reduction in cost and the reduction of time in the hospital for the patient.
I got a question. So we went down this road where at our institution about 10 years ago, and our GI support wasn't so robust. But now it is, and we're doing ERCPs usually same day as the lap chole, or sometimes the same anesthetic. My question for you is, if you have that situation, do you think there's still a role or a benefit of doing laparoscopic common duct exploration?
I think there is, in the sense that you can get everything done consistently with a single procedure by a single team and a single anesthetic. If you're in a setting where you can do this routinely under the same anesthetic and work very closely with GI, I think that's also a very reasonable approach. I think in general, this is not something that should supplant the use of GI and ERCP. I think these are two things that should be used in concert to manage patients with choledochal lithiasis. There are many patients whose anatomy or the location or size of their stones make common duct exploration unfeasible, or is going to take way too much time because of the number of stones. And in those cases, in particular, we need to have a good relationship with our GI colleagues.
All right. Thank you very much.
Actually, one last question for you. So can you tell us a little bit about your approach? Do you do all of these transcystic? And then in the 3 failures where the patients say you're unable to, what's your approach for management?
Sorry, what was the last part?
So if you're unable to do it, if you're unable to cannulate transcystic or in those 3 failures, do you have any other things that you'll try to do in the operating room?
So for those 3 patients, they happened early in the course, and it was more related to equipment issues, just sort of familiarity with that. In general, we've been pretty successful since then. However, our rate is not 100%. So those patients, the plan, usually if we don't successfully cannulate the duct, I usually use wire access. Some of my partners don't. So then they'll move to wire access, flushing, and balloon of the cystic duct. If none of these things work, we don't move to a transcholedochal approach. We have done a few transcholedocals in specific situations. However, I think the safety of the laparoscopic transcystic approach is what's so appealing of it. And in those patients, and that's not feasible, we prefer to stop the procedure and let them get ERCP afterwards.
Thank you. So the title of our next talk is Pancreatic Necrosectomy, NSQIP Predictive of Complications and Mortality.
Thank you, Dr. Euchre and Dr. Chow. So we're going to talk about severe acute pancreatitis and necrosectomies. And this is a substantial cause of admissions and cost. About 20% of these patients go on the necrotizing pancreatitis or walled off necrosis. And about those patients who get necrosis and get infected, the mortality rate traditionally has been quite high, 30 to 40%. Traditional management was open necrosectomy, and that usually meant open abdomen, repeat trips to the operating room or in the ICU with a lot of difficulty, very unpleasant, unrewarding operation with a lot of difficulty knowing what was alive, a lot of mass inflammation, and a very sick patient. In 2010, the Dutch Panda trial came out, which suggested a step-up approach, which was basically to do antibiotics and endoscopic and percutaneous IR drainage before surgery. And with that, they showed a reduction in complications, particularly in multi-organ failure, although no difference in mortality. The surgery for this was VARD, or video-assisted retroperitoneal debridement, which is basically making a small incision and using a scope to help clean out the retroperitoneum. And the step-up approach basically means that initially we don't do surgery, we temporize with antibiotics, we manage ongoing sepsis with percutaneous drainage or endoscopic drainage, we repeat that as necessary. If it continues beyond 3 weeks, then we look at endoscopic debridement versus MIS debridement by something like a VARD procedure. A laparotomy is a kind of a last resort. Hopefully the patient then progresses to resolution, but they could end up having a complication like abdominal compartment syndrome, ischemia, perforation, or hemorrhage, which could result in laparotomy. And the VARD procedure is something that's not too hard to learn, but basically we wait until a patient has a nice ripe retroperitoneum, has infection in there. We make a subcostal incision, go in the retroperitoneum with the scope, and with something like a ring forceps, we dig out all that cheesy, dead necrotic material and help them manage their sepsis. So we hypothesized that there were preoperative and laboratory factors for death in intensive care unit stay. During the period of NSQIP from 2007 to 2019, we also sought to see what the time trends were, whether there was a change associated with the adoption of the Panda trial results. And this was a retrospective study looking at NSQIP from 2007 to 2019. So we collected mortality and class 4 ICU complications. We looked at lab values, functional status, return to the operating room, modified frailty scores. We looked at predictors outcomes by univariate and multivariate analysis. We looked at time trends, basically and also just in terms of absolute numbers and percentage of cases in NSQIP. So in NSQIP, these are the numbers of necrosectomies that are done. So it seems relatively consistent. However, we have to remember that NSQIP grows every year. And so in 2007, there were 183 cases, hospitals rather. And then 2019, there were 719 hospitals. So there's a lot more cases in NSQIP. The nature of the hospitals has also changed. The hospitals joining now are less likely to be a tertiary referral center. So if you look at the numbers in terms of NSQIP cases, there's actually been quite a significant reduction in the number of necrosectomies that are being done. And the red dotted line by comparison is Whipple procedures. You see Whipple procedures gone down about 20% in NSQIP, whereas necrosectomies have gone down about 75%. And if you look at when Panda came in, that was 2010. So it suggests that there may be an association with adoption of MIS approaches at that time. Deaths and complications, over the period, the number of complications has gone down for each case, whereas the mortality has not changed all that much, which kind of reflects what was found in Panda. Interestingly as well, return to the operating room also went down for what went from as high of almost 50% before Panda to now it's around 10%, which indicates that a lot of single procedures are being done, which is more suggestive of a minimally invasive necrosectomy and not an open necrosectomy. So perhaps MIS approaches are being adopted. Functional status and frailty scores are still important. They're highly predictive of death and complications. Frailty score over time is going down, which indicates that patients are being selected with less comorbidities, and maybe that's why complications are decreasing. And regression scores show that frailty index emergency cases and albumin are the most predictive factors, the strongest factors in terms of complications and death. So we see the number of necrosectomies has gone down quite a lot. Less frail patients are being selected, probably because there's an adoption of the step-up approach. Mortality rates didn't change that much. There's a lot of limitations here because NSQIP doesn't tell you the order of procedures, exactly what procedure was done, the timing of necrosectomy after onset of pancreatitis. So there's a lot of room here for additional study to be done. So we can say that the step-up approach probably has been broadly adopted since 2010, but we definitely could do with more study and understanding of the indications and timings of these procedures. And I would suggest that if we have EGS registries, that pancreatic necrosectomy should be one of the procedures we track in that. Thanks very much.
So when you look at the decrease Do you think is it only from the utilization of the step-up approach? Are we getting better as surgeons on deciding who to operate on early, or are we changing the timing of when you're operating on them?
Well, NSQIP just captures procedures. So an assumption we're making that NSQIP is representative of what's going on in the country. So actually it's several countries because now other countries contribute to NSQIP. But the impression I have is that fewer necrosectomies are being done, but they're more likely to be a single procedure. So the belly's not being left open and the patients are doing better in terms of complications. So it seems to me like people are doing MIS. The question I can't answer is like how many of these folks had previously had a percutaneous drainage or had an endoscopic drainage, but it seems like surgery has moved into more of a secondary role and the results are generally better in terms of complication. Interestingly, surgery doesn't seem to help with death. And that may be because patients who die from this disease are dying from things that aren't related to what the surgery fixes, which is the sepsis.
Eric Peltz, Kalispell, Montana. I was going to ask, do you have any data on the endoscopic trends over that same time from 2007 to current? Because as we've seen technology improve, there's this trend in taking some of our more frail patients or the ones that may not tolerate general anesthetic or the long interventions to endoscopic. And so there's been an increase in transgastric necrosectomies. So is that peeling some of these frail patients off, and maybe the total necrosectomies are now just being done in two different specialty disciplines?
Yeah, I think, and one of the comments we'll make in the manuscript is that the management of this condition should be multidisciplinary. And there have been papers written about how general surgery and GI and IR have to work together as a team to do this properly. Unfortunately, NSQIP doesn't tell us anything about what the GI surgeons did, whether the patient had a percutaneous procedure or not, and doesn't tell us the order of things either. So, and we have to have a different database for that. And unfortunately, I can't find one that actually describes that. So we're basically looking at indirect data, but absolutely, I think, this should be a coordinated approach, and surgery, should jump in when there's complications or when the less aggressive approaches are not working.
Well, thank you for sharing and great presentation.
Thanks.
Yep.
So the next talk on the list is not going to be presented. It's a recorded presentation, so you can look at that on your app. And the next one that we'll present here is negative pressure on bowel anastomosis does not correlate with anastomotic leaks by Reed Bartholomew.
Thanks for having me, everyone. I'm Reed Bartholomew. I'm a PGY4 at University of North Dakota. I have no disclosures to make. So there's a lot of reasons to leave the abdomen open. One is a damage control laparotomy. That's when patients are too hemodynamically unstable to tolerate a procedure. So injuries are quickly temporized. Patients usually left in discontinuity if there's a bowel resection, and they're sent up to the ICU for further resuscitation. An abbreviated laparotomy is done for a similar reason when we're doing emergency surgery and we're just not sure if the organs are viable or if there's just a gross amount of stool or other contamination. We'll leave the abdomen open. When the abdomen's open, what we do is been using intra-abdominal negative pressure. This is where we place an absorbative material into the abdomen, and then it's an occlusive material is placed over the sponges. It's attached, then it's attached to a vacuum device. There's randomized control trials that says this has been the superior method to handling an open abdomen. So our hypothesis is placing negative pressure in an open abdomen when a new anastomosis is created, and will lead to an increased leak when compared to patients that have a anastomosis made at the time of closure. So we did a 8-year retrospective cohort study from an existing database done at Sanford Medical Center, Fargo. In this time period, there's 404 patients with open abdomens. The two groups, our treatment group, the one where there's negative pressure placed on a new anastomosis, had 77 patients. And the control group, where the anastomosis was made at the same operation as closure, had 76 patients. The remaining patients had either an ostomy or they had no bowel resection. Our primary endpoint is anastomotic leak rate. Secondary endpoints are time to closure, time with negative pressure on an anastomosis, number of operations, time on vasopressors, time in ICU, time on ventilator, and mortality. Patient characteristics, none were significant. Gender was about even, age was about the same, and Apache, there was no difference in Apache 2 scores as well. So our anastomotic leak rate ended up not being significant. The treatment arm had a 19.7% leak rate. Control had a 13% leak rate. P-value was 0.363. Our secondary endpoints, we did see a significant difference in time to closure, with the study group taking longer to close than the control group. And then significant differences in time on ventilator and number of operations, as well as time in the ICU, with the treatment group, with the study group all having longer times. There were no differences in mortality. The study group had 15.8%, control had 18.2%. No difference in complications and no difference in time on vasopressors as well. So based on these results, I think we can say that negative pressure wound therapy in an open abdomen has no association with an anastomotic leak. This was a retrospective cohort study, so it wasn't prospective or randomized, so there's room for growth there. There were patient characteristics were not significantly different between the groups. We could use something like ASA classification or wound classification or wound contamination class to better delineate which group was, if one group was more sick than the other group. And then we could stratify reasons to keep the abdomen open and compare them, hemodynamic instability versus organ viability versus contamination. In conclusion, there's no, the study did not reveal any statistically significant difference in anastomotic leak rate between the two groups. So I think it's safe to say at this point that placing negative pressure on an open abdomen will not lead to increased anastomotic leak. And because of this, we've changed our practice when dealing with open abdomens and bowel resection. Thank you.
All right.
Eric Peltz, Kalispell, Montana. It's a great study. My question for you, do you have data on the duration of negative pressure that you applied to these patients? Because it's both the application and then the temporal relationship, right? The longer we leave an abdomen open, the longer we leave negative wound vac therapy on, there's a predilection for interatmospheric fistula. So are these patients 1 day of negative pressure and then they close? Is it 5 days or did it matter? And I would ask along that same line with your leaks in the anastomosis, were those longer negative pressure therapy or was it irrelevant how long they had the therapy on?
Yes, so we did look at that. There was a trend towards more leak rate the longer we left the negative pressure on the anastomosis, but there was no significant difference.
Good morning. This is great work. Ryan Lawless from Denver. Question about lab values and indications for either putting patients back together or leaving patients open, right? So oftentimes we'll ask above the drape, hey, what's the base deficit? How much pressure are you on? That kind of stuff before we put patients back together. Did you look at any of those characteristics of the anastomosis that you created? And to follow that up, in patients that, my bias, can't stand the open abdomen. So here's my question with that caveat. How many times did you put the bowel back together, take the patient back tomorrow, and then close the abdomen? Because in my opinion, when you want to go back and just look at that anastomosis one more time, that's probably the unnecessary risk of leaving the abdomen open one more day to make us feel better and not really help the patient.
So to answer
Base deficit.
yeah, thank you. We only looked at this indirectly, just when they were admitted with the Apache 2 score. Otherwise, we didn't look at any other labs, but that would be a good thing to do. And I think the majority only had one operation and then closed on the second time. But there is no difference in number of operations compared to leak.
Ali Bavaraja, University of Arkansas. My question is, how did you manage your control group? So the study group had a negative pressure therapy. How was the control group managed their open abdomen?
How was the control group managed?
Yeah, how was their open belly managed? What
It was
did you use?
sure. It was done with an industry wound vac.
So that's the study group. What about the control group?
Okay, so they were both open abdomens with negative pressures. The study group had the anastomosis made and then it was sent back to the ICU with negative pressure. The control group had negative pressure on an open abdomen, but the anastomosis was made on the day of closure.
Gotcha. Thanks.
Hi, Roxy Albrecht from Oklahoma. A question kind of spinning off those two is, did you have any protocol to look for ACS or secondary abdominal compartment syndrome in those patients? Were you
No,
measuring bladder pressures? Were you looking at some of the endpoints of resuscitation as we talked about?
We did not, but in both our study and control group, none of those patients had abdominal compartment syndrome.
Okay, thanks.
Thank you very much.
Thank you.
And actually, that was a Lowry Award eligible presentation. So the next presentation is the impact of early antibiotic administration on outcomes of necrotizing soft tissue infection. And this is from Dr. Kim from Rush.
Hi, good morning. I'm Seungjun Kim, a PGY3 from Rush University Medical Center in Chicago, Illinois. So our project was on the impact of early antibiotic administration on the outcomes of necrotizing soft tissue infection. I have no conflicts of interest to disclose. So necrotizing soft tissue infections are associated with high morbidity and mortality rates, with mortality in the 20 to 25% range historically. And the cornerstone of treatment has included prompt antibiotic administration and early aggressive surgical debridement. Previous studies have shown that surgical debridement within 24 hours and even within 6 hours is associated with improved outcomes, but evidence is lacking regarding the timing of antibiotic administration. So the aim of our study was to determine the impact of antibiotic timing on outcomes for NSTIs, with the hypothesis that early administration would result in decreased length of stay and decreased mortality. We retrospectively identified adults, at least 18 years old, who underwent debridement for NSTI between 2015 and 2020. We did exclude patients who were transferred from other hospitals. And we defined time to antibiotics as the time from registration in the emergency department to intravenous, the first IV antibiotic administration, and stratified it into 3 groups as 3 hours, less than 3 hours, 3 to 6 hours, and greater than 6 hours. So there are a total of 61 patients in the study period. The mean age of the patients was 52, and about half of the patients were female. There were significant comorbidities in our group, including 49% with obesity, 64% with diabetes, and 20% with CKD or ESRD. Of note, our overall mortality rate in our study population was 5.5%, which is lower than described in the literature. Our average time to antibiotics was 274 minutes, and the average length of stay was 16.5 days. We found that on univariate analysis, time to antibiotics was significantly associated with hospital length of stay, with a time greater than 6 hours associated with an increased length of stay compared to the less than 3 hours and the 3 to 6 hour groups. On multivariate analysis as well, time to antibiotics was the only significant factor, with the other comorbidities and age that were not significant in the final model. Some of the limitations of our study include that it was a single center retrospective study. And so as we all know, correlation does not equal causation. We also didn't stratify by bacterial culture data, whether it was polymicrobial versus monomicrobial, the specific anatomic location, and stratifying it into fasciitis versus myositis or cellulitis. Our low mortality rate is more consistent with more recent literature, with 2 studies that have reported rates of 8.3% and 12.5% compared to the more historical rates in the 20s. And so Our conclusion is that IV antibiotic administration within 6 hours of presentation for a necrotizing soft tissue infection is associated with decreased hospital length of stay, but not mortality. Thank you.
Thank you.
So in our hospital, we've seen quite a bit of a delay, at least in the with a high number of patients coming in, especially with COVID. As surgeons, we sometimes don't see these patients until a lot later than 6 hours. So are you guys usually seeing these patients within 6 hours? And if not, what are you doing in your system to make changes based on this?
I do think that surgeons are often called well after, and I think that this will require coordination with the emergency department because these are maybe more systems issues in terms of they have policies to get blood cultures before starting the antibiotics. So if they have a difficult blood draw, then that may delay the initiation of antibiotics well before the general surgeon is called to see the patient.
Hi, Paul Bjordahl, Sanford Health. Thanks for a great look at this. On the same line of systems issues, did you record time to debridement, which we know is going to be a big determinant of outcomes? And maybe the time to antibiotics is just a marker of time to recognition and therefore debridement.
We did also look at time to the operating room and similarly stratified it into less than 12 hours, 12 to 24 hours, and beyond 24 hours, which was significant on its own, but actually in a multivariate model, only the time to antibiotics was significant.
Hey, I'm Sumi Rhoda, resident at UT Austin. Sometimes, as going off of Dr. Cho's question, sometimes medicine or the ED has started these patients on antibiotics that aren't the appropriate antibiotics. And once we see them, then we start them on Clinda and the broad spectrum antibiotics. Were you looking at those antibiotics being started or any sort of antibiotics being started?
For our purposes, we had just looked at any IV antibiotics as even to run our preferred regimen for broad spectrum, it would require multiple different antibiotics that often can't all be started at the same time.
Thank you.
Okay, our next presentation is Presentation and Outcomes in Older Patients with Appendicitis by Leonardo Alanis from UC Irvine.
Everyone. Thank you for having me. My name is Leonardo Alanis. I'm a third-year medical student from the University of California, Irvine, and I'll be presenting on the presentation and outcomes in older adults with appendicitis. So I have no disclosures to make. So acute appendicitis is one of the most common intra-abdominal emergencies that results in patients coming into the ED. And as you all may know, most research that's out there is focused on the pediatric younger population, just because probably acute appendicitis is more common overall in this demographic. But on the flip side, there's very minimal research in the geriatric population. Again, probably because there's just a smaller overall rate of cases in this population. The research that is already out there suggests that there might be treatment differences, probably due to, first of all, a delayed detection in acute appendicitis, which may be due to older patients waiting a longer period of time to come in. And once they do come in, there might be a longer period of time before clinicians actually manage acute appendicitis in these patients with surgical intervention. So there's also a higher rate of non-operative management in this population, all of which could potentially lead to a higher risk of perforation. So our hypothesis for this study was that older adults, so increased age, is associated with more complex treatment, which can lead to higher number of complications, higher length of stay, and higher overall hospital charges. This was a retrospective review of 689 cases from the years 2014 to 2020 at a level 1 academic trauma center. We collected demographic variables as well as clinical variables, including appendicitis severity, which was perforated, non-perforated, perforated with peritonitis, and perforated with abscess, as well as procedure type, converted, open, or lap, complication rates, hospital length of stay, ICU, length of stay, and final outcome, so deceased or alive. Exclusion criteria consisted of patients who had surgeries where an appendectomy was not the primary procedure, for example, debulking surgeries for metastatic ovarian cancer. And as far as statistical analysis, we coded categorical variables as present or absent, and then utilized Kruskal-Wallis and Met-Winnie-U tests to compare clinical outcomes. And all of the continuous variables were reported with medians as medians, and categorical data was reported as percentages. After that, we divided patients into 5 age brackets, as you can see on the screen. And for simplicity, we grouped them into either perforated appendicitis or non-perforated appendicitis. After that, we ran a multivariable logistic regression model to find the magnitude of association between increased age and increased risk of perforation while controlling for other covariates. So we found that patients with perforated appendicitis had a higher median hospital length of stay, 3 days versus 1 day, higher percentage of post-op complications, 29% versus 4.4%, and a higher median overall hospital charge, almost $66,000 versus almost $44,000. A regression model told us that each additional decade in age was associated with a 31% greater risk of perforation, and more specifically in the group 65 years or older versus the group less than 18 years of age had a 159% higher risk of perforation. So our study did indeed find that older adults are at higher risk of presenting with perforated appy. And actually previous study found that the main contributing factor was a delay in older patients coming in after they experienced symptoms, and then also a longer duration of time before the appy symptoms were treated surgically, all of which leads to higher length of stay, higher complications, and higher hospital charges. So in conclusion, our study suggests that we need more studies, ideally randomized control trials, to guide us on how we can be more vigilant and perform more time-sensitive screening in order so we can catch these acute appy cases sooner. And we also need a standardized algorithm for the management of acute appy, particularly because different regions have different kind of like methods of whether or not they're going to manage it operatively. For example, the United States versus Europe, where there's an increasing trend of managing appies non-operatively. And that's our references. Now I'll take any questions.
Well, that's a nice presentation. Congratulations for doing a presentation as a medical student here. That's always impressive. My question, I don't think this data surprised us too much, but are y'all doing anything with this information clinically to try to, diagnose and treat these folks earlier to avoid the increased perforation and complications you see in the older patient population?
Are we doing anything ourselves?
Yes.
Not that I'm aware of, but if I could see something like change in the future, I would say we could potentially lower the threshold of symptoms and when we would actually send somebody to get a CT or even an ultrasound, for example. I know at UCI we're kind of trying to popularize ultrasound even more. We're teaching the medical students how to do ultrasound. So perhaps when we have a higher training level in the workforce, not just at UCI, but in other places, maybe we can implement ultrasound more frequently and just give it more access to the general population.
Okay.
Yeah.
Dr. Dent.
Yeah, Dan Dent, San Antonio. Nice presentation and group of data. My question, I guess, is kind of similar to Dr. Eaker's. Our group presented here probably 25 years ago that 80% of the patients were perforated before they ever sought healthcare. And there's not a lot we can do to solve that other than maybe public education, that sort of thing. And that kind of goes along with a different paper that showed the #1 predictor, at least in young people with appendicitis, of not being perforated is previous sibling with appendicitis. So once mom learns how to recognize appendicitis, she'll get the second kid there early. And so it's a public health, public recognition issue, not a healthcare system, the way we currently think of healthcare systems anyway, problem. Now, were you able to tease out how much of this was after they sought initial healthcare? Because what we saw was 80% were perforated before they saw anybody. Over 10% perforated between seeing the primary care doctor or the first doctor they saw and a surgeon, and about 8% perforated after seeing a surgeon. So that's when we think more globally in big health systems, we're thinking of that 20%. But if you want to think about patient education, you can start now approaching the full group. But how do we do this? How do we approach this?
Yeah, no, I agree with you. That's definitely a public education issue, first and foremost. That was actually one of the limitations of our study, was that we weren't able to acquire the data of patients who had previously sought any sort of medical help for an episode of appendicitis. So we were actually discussing that and for future, like a follow-up study, we might see if we can get some of this data to see if the initial non-operative management eventually led to higher perforation rates. That way we can see if this is actually like an issue in the medical healthcare system versus public education. Yeah, thank you.
Good job.
So our next talk is a clean sweep initial experience with a novel intracavitary laparoscopic cleaning device, and with Dr. Rauer.
Hello, my name is Simine Roward from the Dell Medical School at the University of Texas at Austin. I'll be presenting a clean sweep initial experience with a novel intracavitary laparoscopic cleaning device. So for anyone who's done laparoscopic surgery, this picture on the right is unfortunately seen way too often. A frequently encountered problem in any laparoscopic surgery is an impaired visual field. Studies have shown that only about 50% of laparoscopic OR time is spent with a completely clear visual field, with up to 7% of time spent cleaning the lens. The current gold standard solution requires between 20 to 60 seconds to remove the scope, clean, and replace the dirty scope. And this interruption happens about 3 to 10 times on average for each laparoscopic case, and this can sometimes be more frequent depending on the type of case. So the NALCD is designed to adequately clean a laparoscopic lens quickly and efficiently without requiring removal from the surgical cavity. It's essentially a windshield wiper for the laparoscope that works with most existing laparoscopes and trocars. This study aimed to describe the efficacy and the initial human experience with the device during actual laparoscopic operations. We hypothesized that intracorporeal lens cleaning could significantly impact the field of laparoscopic surgery by minimizing operative time and surgeon interruptions and distractions and frustrations, and consequently decreasing operative complications and cost. Here you see a picture of the NALCD. I also have it here. It is compatible with existing trocars and laparoscopes, and it can be used with one hand or two hands. You can see the NALCD in action here. Being able to remove blood with one sweep is very helpful. A big problem that happens in most cases is condensation fog that occurs because the camera is too cold. And as you can see here, sweeping it is able to clear that fog and condensation. You can also see that with use of Bovie electrocautery, sometimes you have the smoke that requires cleaning as well. And the NALCD is able to remove that as well. In cases with a lot of inflammation, sometimes tissue debris and tissue oils can also be very problematic, and the NALCD is able to remove those as well. So the NALCD was used in 167 cases with surgeons at 12 different institutions in Texas, California, and Massachusetts. The rate of scope removals in each case was examined. Following each trial, the users were asked to rank the NALCD based on ease of setup, insertion, adjustment, and cleaning efficacy. A survey was then used to evaluate surgeon satisfaction after each case. One change that was made halfway through the study is that spacers were used for precise distancing of camera and scope. Unfortunately, laparoscopes do not all come in the same size, and the spacers allows the scrub techs to measure this distance and allow for an exact cleaning each time. Our results show that the NALCD was tested in a variety of cases, including colorectal, gynecological, general, pediatric, hepatobiliary, thoracic, and bariatric. The NALCD usage eliminated the need for scope removal in 90% of debris events, with only 97 removals in a total of 984 events. A majority of the users reported that using the NALCD improved their visual field. Surgeons give an average score of 4.56 for ease of setup, 3.9 for ease of use, and 4.12 for ease of operation and cleaning efficacy, and this is out of 5. Here you can see the results of our data. Our first initial 1 through 35 cases are seen. As you can see, with the introduction of the spacers, satisfaction and ease of use also went up. And again, you can see here the introduction of the spacers allowing for increased satisfaction and ease of operation. This shows ease of insertion, operation, and ease of use based on specialty. And here you can see a table with the total number of events and the number of times that the use of the NILCD mitigated removal from the camera. So in conclusion, in our initial analysis of 167 cases, the NILCD proved to be effective and convenient method of cleaning the laparoscopic lens in vivo across a variety of surgical disciplines. Initial surgeon satisfaction was positive and has improved with the implementation of the SureFit spacers. Thank you.
So thank you for sharing. That's a unique device. I think for anybody who does laparoscopic surgery, that's probably one of the problems is having visualization. So after the initial 160 cases, what have you learned and what are your next steps? And do you think this will be adopted more widely for use?
I think after the first 167 cases, the reception has been very positive, and you could see in the charts that the more surgeons use it, the ease of use becomes easier. And I think that going forward, it will be implemented in more hospitals and more different types of laparoscopic surgeries as well.
Couple of questions. First, is this a reusable device or is it a one and done, like a peel pack thing? And what's the cost?
Good question. So the cost for each of these is about $75, I believe. And these are a one-time use.
And I know this is a kind of a loaded question because it's hard to gauge, but did you look at, examine, or in any capacity see how it may have improved OR time or case time?
Good question. We did not look specifically at OR time, but in the experience of the surgeons that have used it, especially once you start using it multiple times, the time for setup, really the scrub tech sets this up in the back table, and that doesn't contribute to OR time at all. And if you think about the time to remove a scope, to put it, to clean it, and then to do that repeatedly and repeatedly, OR time will actually be quite less using.
Well, that's actually what my question really was, is did it decrease OR time because you're not having a fuss with pulling the scope in and out 17 times in a case?
Exactly, yes. Thank you.
All right, our final presentation is impact of chronic opioid use on short-term weight loss following laparoscopic gastric bypass by Madison Heron, Greenville, South Carolina. There pass. So are we done? Okay, I guess we're done.
All right.
Thank y'all.
Well, we'll give you guys back a little bit of your morning, but I think the next session will be in here at 8:15. So we'll give you back almost half an hour of some Hawaii time.